Hello, everyone. Welcome to TACMed Simulation and the opportunity for us to do this webinar with you in conjunction with GSOF. My name's Dan. This is Rudy. We're going to be hosting this webinar with you here for the next hour or so. Just a quick rundown of what we're going to try to cover is where these mannequins, where the simulation came from, what the purpose of them was, what the genesis of them started off as. We're going to talk about the features of the mannequin and how we can use those to test both the individual rescuer, prolonged field care, and actually throughout the entire continuum of care. There's a lot going on there, and we're excited to show this feature off. But before we get into all of that, we just want to get to who's who in the zoo, do a brief introduction. So Rudy, if you could introduce yourself, and then I'll follow up after you.
Sure. Good afternoon, everybody. My name is Rudy Palacios. I am with TACMed Simulation. I'm a retired Air Force medic. I've been with the company since 2011, when it was Trauma Effects now, which is TACMed Simulation now. I'm a sales engineer manager, and I am glad to be here and to go over this webinar.
My name's Dan Stout. I work for Tactical Medical Solutions. Long time ago, I was a very nasty Marine Corps reservist while I was going to school. Never deployed. Toys for Tots was about as hoorah as I ever got with that. Great opportunity, though. Did nothing but benefit me throughout my career, which ended up being my wife and I both served for 25 years with the Gainesville Police Department down in Florida. And we both retired as lieutenants back in 2018. Yes, I was a lieutenant. My first name's Dan. Magic legs, ice cream, all of that. You just got to have fun with it. The one thing about my career that was a little bit unique and different is after Columbine High School, I went back and cross-trained as a paramedic and ended up doing the whole SWAT medic thing for 14 years and helping our agency and other agencies there in North Central Florida roll out IFAC type programs and get into the whole medical side of things post-Columbine, and was able to parlay all of that into what I do now here at Tactical Medical Solutions. All right, so brief introductions, just so you know who's up here talking. Before we dive into the talk about the mannequin, if you have any questions throughout the presentation, if you would type them into the chat box, and we're going to get to all of the questions at the very end. We're going to be pretty thorough and hopefully hit as many of the information that would probably come up in questions anyway as we go. But just in case there's something out there that we don't hit on that you want answered, please just type that into the chat box, and one of our associates here is going to read the questions off to us at the end so we have a chance to properly respond to them. All right, so Rudy, where did these things come from? What was the purpose behind why these were designed?
Well, Dan, this started back in 2009 before I joined the company. 2009, we had a project with RDECOM. We were tasked to create a blast injury, how to care for a blast injury. And we partnered with Jamie Hyman from Mythbusters, and also with them with Industrial Light and Magic from Lucasfilms out in California, Northern California. And with them, they created the very first ever MAT. MAT stood for multiple amputee trauma trainer. It was mobile amputee lower, and it bled and it moved. Okay, great for tourniquet training.
Okay,
right, and then we did that, and the Army loved it, and we built quite a few for them. And from there, we've come a long way. We've come from full body systems to clinical response to canine trainers as well, and tabletop task trainers.
All right. So this was originally, the genesis came out of the Department of Defense.
Correct.
All right. Where are these things being used at today?
Right now, we got over 3,000 of these units out in the field right now, all over the world, actually, all over the world. Anywhere from Japan out to California and all over the United States, and almost every Army base right as we speak right now, and quite a few Air Force, Navy, Marines bases as well, and quite a few civilian agencies as well. So they're out there.
All right, very cool. So there's a lot going on with this particular mannequin. What is the model? What do we call this particular mannequin that's here in front of us right now?
First of all, you want to look at is TACMed Simulation is how realistic it looks and feels. That's what we're known for. Okay, this is our Clinical Response Resuscitate Upper, a CRU-R is what we call it, and our Clinical Response Lower, or CRL. So we call it the clinical response whole body system. So we have here in front of you right now. It's one of our high fidelity mannequin that we have, or similar that we have. We have mid fidelity and low fidelity as well, as far as task trainers that we have in our profile.
So when you're saying high fidelity, what does that mean exactly as far as like who can actually work on this system and practice their skills? What level of clinician encompasses this system?
Well, you can go away from the field. You can go from the point of injury, either be military or civilian, the point of injury all the way to the emergency room and even to prolonged field care. So we can go from the start and almost all the way to the finish. Okay, you can run them from just doing basic stop the bleed all the way to starting IVs, intubating them, doing them IVs as well, central lines, Foley catheters, you can go all the way into the pinnacle space of it as well.
Very cool. So combat lifesaver level soldier training, police officer
Correct.
level training, all the way to the actual surgeons and doctors in the trauma center and every level in between.
Correct.
All right, very
Correct.
cool.
Nurses, medical technicians, physicians, all levels. This model here, we'll start at the head. I'll give you some of the features starting at the head itself. Start from the head all the way down to the toes is a lifelike feature we have. Okay, this one here, the eyes actually respond to the light. Right now they're normal, but if I go ahead and put a light on the actual eyes, they will respond. This one I have set for normal, and they will constrict once the light hits it. See how it constricted? Take the light away, and it goes back to normal. Okay, you have 4 settings with these eyes. You have normal down to TBI, constricted and dilated, and they can be managed by the remote control.
So when the student's doing patient assessment, that's one of the things that they're going to be looking at to do a good quality assessment of the patient. That makes it more realistic, correct?
Correct. So that's exactly. Okay, so from the eyes we go down to the nose. The nose design, you can put an APA and eat on right or left nostril. Okay, you can put it all the way in, or you can block it out where it doesn't go in. Okay. From the nose, you go down. There's also sensors built into the nose. When an MPA is placed in, it shows up on the remote that it was placed inside the simulator.
And placed correctly.
Placed correctly, correct.
Very cool.
Going to the teeth, you have lifelike teeth and tongue. You can do a nice jaw thrust with them, like the way the jaw moves. Okay, actual lifelike teeth and tongue, and like a patient or a patient who is unconscious, the tongue falls back as well, so it gets in the way. Okay. You can intubate it, and you can't see really in there, but lifelike airway. If I put too much pressure while I'm intubating, I put too much pressure on the teeth, it shows up on the remote control that I'm putting pressure on the teeth. And if I put way too much pressure while I'm intubating, I can break the teeth off, and they do come off. Luckily, this is on a magnet, so it goes right back in, just like that. Okay. Besides that, you can block off the airway.
When you're doing your intubation, whether you're just using an old school laryngoscope with a light or one of the newer video laryngoscopes, do they actually get to visualize the vocal cords?
Yes, we worked very hard with our local anesthesiologists to create a lifelike airway, and I think we did that. If you go in there with the stethoscope and look in there, I mean with a laryngoscope in there, you'll see the cords, and you see everything that's in there, how lifelike it looks. Okay, like I said before, while you intubate, you can block off the airway, which makes it more difficult to intubate. If they can't intubate, then they go to cric.
All right.
They can cric the same way. It's lifelike. You can cut into it. We have 3 types of skins on our cric skin here. We have pre-cut for training. You see this is pre-cut for training from start to finish here, A to point B.
And you just tape over that in
You
between
can tape over if you
runs?
need to. We also have skin that you actually have to cut into. And the third skin that we do offer is a skin that actually bleeds when you cut into it.
That's so cool.
It makes it real lifelike as well. Okay. When you intubate or cracking it, if you intubate correctly, you bag him, you have rise fall of the chest correctly. If you go too far in, you get right manstable. Only one side is going to rise. Okay. If you go in the esophageal, and you bag it, you'll get gaseous distension. And all that is captured on the remote control right here. So the instructor, you're looking at this. What's nice about this is the instructor, you don't have to be on top of the student watching. You can stand back with this quite a bit of ways and watch what's going on via remote control. Okay. Well, how about hearing, talking? He does talk, he does listen. Okay. Via two-way comm, the instructor will wear a two-way headset, and they can hear what's going on in this area and respond through him.
And be the voice for the
Be the
patient.
voice for the patient, exactly.
Very neat.
Okay. So again, for the correct there, you have pulses. You have carotid pulses bilaterally. You also have pulses bilaterally on the radial. On the left femoral arm, you have a pulse here, which you can do a blood pressure cuff reading on this one with a manual cuff and manual stethoscope. You have bilateral femoral pulses, right and left. And last one is down on the pedal pulse on top of the foot. So you have pulse points there as well. Coming from here as well, you have a spot where you can do an IO in the ulcers, run some fluids here on the chest. Fluids, you can run fluids and fluids drain out to the bottom of the mannequin. Same thing with you can do an easy IO or a manual one.
All right.
On the arms as well, we can run IOs as well. You can do the easy IO or the manual ones and run fluids through here, or you can swap these out and do an IM injection sites as well on right and left. That's what's nice about this. You can do a lot of lifelike when you do you use the real equipment on these mannequins. Besides that, you also have your tension pneumo. On right or left side, you have a tension pneumo on right or left. And if you do give them one, you have one side rise and one side without rise. What's nice about this simulator is when you give a tension pneumo, he's going to react that way. He has difficult breathing. Okay, his breathing will increase, his pulse will increase, he'll get anxious. Okay, and then you have to treat that. Just for example, I can do that right now for you. If you want, I'll give my right one, right tension pneumo. When I do that, you'll see that only one side is going to rise. And also on the remote control, you'll see that it's saying that one of them is on. So the instructor sees that. Student sees this. Okay, student feels a pulse is increasing. Every 15 seconds, the pulse increases by 1, and respiration by 1. Pulse by 2, respiration by 1. Okay. Again, if you let that run quite a few minutes, if you don't treat that, patient will die on you. Okay. So to treat that, we need a needle D, correct?
Correct.
I have one here. I have a full size one here, 3¼ length, 14 gauge. So what's nice about this mannequin, you have to feel what in the console space to place into the right area. Once you do that, it takes the full needle, and once you get an air release, you can hear it and feel it come out. And once that's done, you
Also
do this.
return of the chest rise.
You got a slight rise of the affected side. Also on the remote control, it tells you that it was done. You get NCD. Okay, and his vital signs start to come down just a bit. That can be done left or right.
So notice, obviously, we're doing this with a full size 14 gauge needle.
Correct size.
I've been to some trainings where whatever it was that we were working on, the instructors bring out a bunch of little tiny 18 gauge needles to perform needle decompression
This takes the full one.
because they don't want to tear up the system. And you can actually get there and see from 10 feet away where all the other students had gone. You just kind of walk over and put the needle where that was.
Right. This skin is resealable skin. So if I pull out this here, the hole disappears.
How many sticks in that little area right there can you get with a 14 gauge
About
needle?
250 sticks before you start seeing some holes. For instance, I can take this off and I can show you. I did a few. There's been quite a few holes on this one. You can't see the holes there, can you? When you start pulling them apart, you see all the holes that have been there before. So it's resealable skin. It's great for training. What's nice about this simulator, everything that pops off skin-wise, you have replaceables for it. Okay, and it goes back in quite easily. It takes a few seconds, put in correctly, and you're back at it. And you're ready to go again. And you can reset it for another one. Okay, that can be done left or right side. Okay. Coming down to his chest, you also have slots for chest tube training bilaterally. Okay, you can chest tube training, takes the full chest tube, and you can suture in place as well. This skin here, same thing, resealable skin. It'll take more than about 25 sutures before you start seeing some holes in it.
And again, it's just a simple swap out and you continue training.
Exactly. This pops off here, and you put a new one on. Okay, very, very inexpensive to do that. Okay, you see rise and fall of the chest as he's breathing.
How do you replicate the pop through the pleural?
When you pop through the pleural, again, what you'll actually have to use your forceps and to pop through it, because inside we have a pleural space that's made up of this tape right here. So once they pop through here with a needle or with the forceps, it's replaceable. All you do is take it off. You put a new one on, and you're set to go within minutes. For the next student, off it goes. A new piece of tape goes on, it goes back in, and you're set to go again.
Very cool.
Very, very simple to use. Very simple to use. Like I said, you have rise and fall of the chest. Okay, coming down here, you have on the left arm, you have a spot for IVs. Okay, you can start IVs here, and you can get a blood feedback.
You actually get a flash in the
Get a
vein when you
flashback.
start it.
Correct.
And
If you hit the vein,
and you can push into the system.
you can run fluids into the system. Okay.
Awesome.
Inside here is a reservoir on its own that holds blood for this IV section here. Okay, IV goes in there. You want to run fluids on the end of his wrist. This cap comes off, and you can run fluids out of it. If you're outdoors, let it run to the ground. If you're indoors, it comes with a bag, hooks up to it, and all the fluids go in there.
Because I've seen, again, other trainings where you just show up and you get all of the pieces and components out that you would need to do an IV, your needle, your tape, your tegaderm, your tubing, your IV bag, and you just make a little pile on the floor next to the arm.
Right.
Oh, I did my IV. No, this one you
This
actually do
simulator
the
is
IV.
great because you can use your actual equipment. You can use on your live page. You use it on these. Okay, like you can start real IV with this as well. With the real needle again.
What about CPR on this upper?
This CRU-R is designed for CPR training. It has a soft, paddable chest where if you do CPR, it does go down. Okay, if you do need to do CPR on remote control, there is a setting for a CPR mode, and once you turn it on, it goes to CPR mode. And once you start doing your compression, it's going to grade you.
It registers your rate and depth.
Rate and depth, correction, and your ratio of good versus bad. Okay, so it does rate you. Okay.
So
again,
in the spirit of CPR and codes, you can actually run the mega codes off of this, correct?
correct. I can run on here. I can run the ACLS and ALS program. Has all the mega codes built into the system, along with a actual monitor. Either use our monitor, or you want to use your own monitor. We have a machine called Vitals Bridge that hooks up to your monitor and to this mannequin.
So the medics on the other end, they get to train with the equipment that's on their rig or in their pack all the time. They're not using somebody else's quotes trainer. They can actually train with their equipment on this man.
Correct. That
Very
is
cool.
correct. Yeah. So you can use your equipment with our equipment and combine it together. Okay.
So being the highest fidelity unit that we have, what about central line ultrasound capabilities on this? Is that available here?
So this unit is available. You have a central line spot to do central lines. Okay. This skin here comes off, and you place it with another skin that is ultrasoundable. Okay.
Very
And without ultrasound, you can fill up the chambers with your venous blood and your arterial blood.
And
when-
you know, in the right one or the wrong.
exactly. So when you go in with the central line, you know, be in the right place or the wrong place. And then when you do ultrasound, you can see both chambers. Okay. Also, you can suture in place as well. If you go with the central line correctly, there's sensors in there that tells remote control that you're in there correctly, or if you've gone too far. Okay. So you have sensors built in there as well. The arm itself, you see, we have a burnt arm on this one. On the right arm, it's burnt. You can get this in with or without a burnt arm. No injuries, a burnt arm, or an amputated arm. Okay. With the amputated arm, you have a blast arm that has a way to put a non-injured arm on as well.
Okay, so you could have in the morning, students are working with an amputated arm, but if you wanted to change things up, you attach the lower arm, put a sleeve over
Yes,
it,
and
and
you have
you're
a
taking
non-
the amputation out of
Exactly,
play.
you have non-injured arm.
All right,
Correct.
that's good.
Exactly. You notice that, Dan, that these divide in two. Okay, you got the center and divide in two for quite a few reasons. A, where you change the batteries at.
Okay.
Battery boxes are right in here. I'm right underneath there. We run off Makita batteries,
That's handy.
Makita drill batteries. Okay, that makes it easier for our customers to get their own batteries if needed. You know, so we're not battery experts, but we went to the battery experts to help us create this mannequin and make it run with us. Okay, depending on which amp you're using, right now we have 5 amp batteries in this mannequin, so you'll get about a good 5 hours use out of them uninterrupted. If you go with 6 amps, we're getting about a good 7 hours use out of them as well. Okay, so again, these are very easy to get a hold of. If you can't get it from us, you can get it from your Home Depot, Lowe's, wherever you need to get them from, or order online. Okay. Also, reason why they separate in the center is because you can use it as test trainers. Okay, I can use the upper for airway training with its own remote. I take the remote and run them somewhere else for training, and I take the lower somewhere else for training. Okay,
And then bring them together to make
two different
the full
training
body.
rooms and bring them together with one remote with one body.
Very cool.
And that's why we have separate in the center. Okay, and they connect with the H bar. And the third reason is because you can mix and match any of our uppers with our lowers. You have a high fidelity upper with a low fidelity lower, or
Okay.
vice versa.
So that just helps continuously change the presentation of the patient.
That is correct. Also, it allows our customers to buy, say they buy one body system here and they want a different lower, they can just buy a lower and match up with this upper. They don't have to buy a full body system.
Okay.
It makes it easier for them to buy that way. Okay. Going down to our lower, you see here, we have quite a few different wounds on the lower. The first wound you're going to have is an inguinal wound. Okay, a packable wound that's going to bleed and requires packing and time and pressure to stop that bleeding. Okay, if I want to start that bleeding, I would just go and hit the button here, start that bleeding, and it starts bleeding. You see how it's flashing red there and it's bleeding? If I want to pack it, hold this for me, Dan.
Absolutely.
I'll pack it for you. I can take this out and start packing it, and you see it bleeds. And once I pack it correctly, you see, if I stop the bleeding, it tells me if I stop the bleeding correctly. It's still bleeding?
It is still bleeding right now.
Yeah.
There you go. Now you got to stop.
So I got to stop now. So I can take the time for 3 minutes to 2 minutes, 1 minute, whatever time I need to create that. I can finish packing it, hold pressure on it, and it will count down from 3 minutes all the way to 0.
So it's not just giving you credit for having stuffed something in the hole. It's got to be the right amount of pressure for the right amount of
Right.
time.
If I let go of it, it's going to continue to bleed. Yeah. Okay, you can. There you go. And you hear that, but what you hear there is the actual pulse, because if you don't want this in play, you put a plug over it, okay, and you get a pulse out of that blood. It comes with bilateral femoral pulses, okay. So again, if you don't want this in play, the hole goes over it, and voila, you get a non-injured right there. Okay.
So we also have an actual arterial bleed on this side with the amputation, correct?
Correct. Exactly. Yeah, I'll start it for you, Dan. So what's nice about this lower here is it has animatronics, so I can make it move if I need to.
Very neat.
Okay, so that way you're not taking care of it. It's
When we've actually got him hooked up, it actually helps make the upper
makes the whole body move.
too.
Exactly,
So
makes
it's a
the whole body
combatant
move.
patient.
Yeah. So again, he moves up and down, side to side. That way you have that's another thing you have to deal with, somebody moving like that. Okay, if I want to make it bleed, I would just turn on the regulating amp and it'll start bleeding. You see it bleeding there, and you turn it correctly, the bleeding will stop on its own if it's done correctly. So
Just
you
by
see,
turning the windlass a little bit, we've already got it
yep,
stopped.
stop, lock it in place. It should be good. Once you lock it in place, there you go. It says stopped. Okay, and of course it's still on, but you stopped it correctly.
So the technology that's in here that makes that stop coming out of the end, is that a sensor, or how is this controlled coming through?
So this right leg, amputated leg, has an artery up and down the legs like you and I do. Okay, so to stop that bleed, you have to put the artery against the bone, correct?
All right, so we're actually pinning an artery up against the
Against the
bone.
bone, yes, you are, up
Very
and down.
good.
Of course, it takes less pressure up here than it does up here.
Right.
If I put a turkey down here, it's gonna take a lot more pressure than it will up here because it's closer to the body here, closer to the skin, right?
Very cool.
So we have that as well. And if you're moving him around after you've taken care of him, and this becomes loose at all, he'll continue to
They'll
bleed.
do a rebleed.
He'll do a
Okay.
rebleed. So again, you have to make sure you reassess your patient.
Constant assessment, reassessment.
Coming down the legs here. Also, one thing I didn't show you is you can do a Foley catheter here as well. You put a Foley catheter in, and you get some urine out.
Okay.
Okay, this unit comes with a set where you can make the urine with the set,
Mhm.
with a kit, and you insert it here into the mannequin.
How
And we
much urine will it hold?
250 milliliters of urine,
And how much blood will the lower unit hold?
1,500 milliliters.
Okay.
Okay, 1,500 milliliters, and it'll bleed out quite a bit. What's nice about this is if you don't treat this bleeding, if you don't stop the bleeding, eventually all bleeding stops, correct?
Correct.
Either I'm stopping or you stop it on its own. This he will die on you.
So if the student's on par and he's doing good, then the mannequin tracks in that direction. If
That
the
is-
student's lost in space, he's going to continue to deteriorate to the point of death.
Of death, correct,
Right.
exactly. So again, it's what's nice about this
And that does
mannequin.
not require you interpreting something and making manual inputs into the control. The
Correct.
system detects whether this is going right or wrong.
This simulator has a built-in physiology of a human body. It's going to react how it's supposed to react. You know, if the vitals will change automatically during the scenarios. Okay, you got 20 scenarios built into the system that you can modify. Okay, whatever it's gonna simulate a live body, and the heart rate will change, the breathing rate will change, the blood pressure will drop or increase depending on what the scenario. What's nice about it is the pulses here. If his blood pressure starts dropping, you start losing pulses.
So I would lose pedal pulse.
Fetal pulse, femoral
working up
pulses.
the body. Okay.
If I lose below 80, I start losing irradial pulses. All I have is carotid pulses. Again, this acts like a real live body. Okay. So that's what's nice about it. Going down to the left leg there, you can do an IO on the left tip area and run fluids. Okay, you can run fluids because the fluids drain out to the bottom of his foot, as you can see there. You also have on the thighs, you have IM injection sites on the right and the left side. You can run IM injection sites right here and run fluids through. Okay, so that's how those work.
So similar to if we talked earlier about if you had the version of the arm that was an amputation where you could make it a full arm or go back to an amputation arm. Here we have an amputated leg. Is there a way to adjust this? So
Yes.
we put a leg back in place.
So the first two models are high and mid fidelity. These bones do come off. Okay, this piece of shrapnel does come off as well. Okay, and you can take this bone off and you put a non-injured leg on or a fractured leg on. Okay, also comes with a sleeve that covers all the wounds as well. So you have two non-injured legs on.
So it's a great way for constantly changing up the patient, because you don't want the students coming in programmed always going to have a right amputated leg.
Exactly.
And we're always going to treat an inguinal.
That we're not expecting the same injuries all the time. You can change them up to a point once in a while. Okay, so you have that as well. So that's what's nice about it. And then actually the fracture looks like a real life fracture. It's a very realistic fracture. Okay.
So obviously, right now he is a male patient.
Correct.
Do we have the ability to convert this mannequin into a female mannequin?
We do have female parts. We have a female breast bib that can go on if you want. Okay. And we also, this penis here does come off, and you can put a female part on it as well.
Okay.
And still be able to do a Foley catheter as well.
Excellent.
So you have options there as well. Now later on this year, we'll have a full body female coming out as far as our profile as well.
Oh, outstanding.
Yes.
Skin intonation. What different nationalities or what types of skin intonation can we do to change the mannequin's presentation?
We have three types of skin. We have what you see right now, and we have the light tone. We have an African American tone and more of a brown skin tone as well. So we have three different tones.
And will that same option be
Across the
available
board
with the female
Yes.
mannequin as well?
Yes. Our female coming out is going to be more with all the limbs will be interchangeable. All the limbs will be. So if you want two non-injured legs, you put two non-injured legs. If you want a blast arm, you put a blast arm or a non-injured leg on them on. All those will be interchangeable on the female.
Very cool.
As far as weight, this one here weighs about 175 pounds. So he's got some weight to him. Okay. He sits up 90 degrees. He will sit up. He'll fit in a car. If you put him in a car for a car accident or anything like that. He goes everywhere.
So he's not just intended to be a stationary task trainer. This thing is meant to be moved and taken off the X, correct?
Correct. He's built to be rugged. Okay. He's rugged enough to be outdoors, and that's what he's designed. But first was to be outdoors. Okay. So you can take him outdoors into the all temperature, from the cold, the heat, the rain. You take him outdoor in the snow as well.
Okay.
Yes. And you can as long as you put a uniform on, you can drag him around if you need to. He'll be fine. You can drag around our arms here. You can rotate quite a bit. It's like your arm and my arm. And you can drag it by one arm and it's not going to fall off on you. So it's very, very rugged. As far as also you can do a lot of like you said, well, clinical. How you mean by clinical? By clinical, you mean with a vital signs monitor or your vital signs monitor, you can run him as a non-injured patient. You can do ACLS program. Okay. You can do PHLTS as well if need to. Also for prolonged field care. Okay, you can monitor him out in the field. If he's not going off right away, so for those scenarios where you have to hold on to him for about 12 hours or more, you can do that as well. That's what he's designed for. That's why we designed him, was for that.
I like the aspect of crawl, walk, run. You can start off just having him as stationary task trainers, breaking them apart, working on upper stuff over here, working on bleeding control over here. bring him together, actually start doing some slow moving scenarios to start working on your skills. But then you can just go all out, and to the point where you actually, we've done everything. The first responders, whether it's a soldier or a police officer, they've done their initial BLS level stuff. Maybe a higher trained medic comes in, gets to do their level of skill. We're packaging him for transport. We're getting him off the X. We're moving him
Correct.
all the way. And whether it's by air or by ground, those transport units get hands on with this guy.
Correct.
And
Exactly.
all the way into the trauma center where physician level
Can do
folks get to do
ongoing
their
care
thing.
with them. Correct. You know, he can go from the point of injury, right, or at the motorcycle accident site, hand it off to the EMTs, hand him off to the paramedics, hand him up into the emergency room, and from there.
Probably one of the neatest scenarios that we got to see these things in play. We had a regional airport down where I used to work, and I think it's every 3 years you have to run a mass casualty exercise, and they bring out like an inflatable airplane.
Yep.
And they get the theater students from the university out to really get into this stuff. But we were able to put a couple of these in play, various levels of injury. And again, those first people on scene, some of were just citizen bystanders, some of it were law enforcement, whether it was, you know, first responder or stop the bleed level type training, they were getting to do some things. Fire and EMS get on scene, rescue task force type operations, they're doing their thing. We sent some by ground, some by air, all of them converged into our trauma center. So the system times and date stamps everything, tells you what was done, when,
Correct.
whether it was done correctly, incorrectly. So we were able to see who did what, when, what worked, what didn't work, did anything not get done, whether gaps in patient care, you know, that kind of thing. It was a really cool way to evaluate literally how the patient care was going. Speaking on after action report, does this thing actually have the capability of providing you with an AAR?
It has an after action report button right on it there.
Okay.
On the remote control, this is very, very easy to use. It's color coded. I've grabbed this remote control, give it to people who have never used it before, and within 5-10 minutes, they're using it.
It is very intuitive.
Very intuitive.
Especially when it went to the actual touch screen.
Yes.
Larger screen is very similar to a
There's after action
phone, iPad.
button here. You can click on it, and it goes into after action. You choose what you want to, and you can view it, and it gives you a report right there in front. It gives you a report of what was going on and what we did, and it's time stamped as well. If you want to save it, you put an SD card here on top. It fills right in here. SD card goes in there, and you save it. SD card, it fills in as a Excel spreadsheet and a log sheet. So you save it. You can put the actual lane number you're on, student's name and instructor's name will go on there as well. Okay, when you save it, when you put it on your computer on SD card, you have two different logs that tells you, and it reads one has the Excel spreadsheet and one tells you timestamp as it minute goes by what was done to them. So again, you have two ways of looking at that.
very cool.
It's very cool. A lot of people like that option, how you use it.
Generally, if you've got a day of training, you want to minimize downtime, people humming and not having something to do. What is the turnaround time in between runs to get this thing back into play?
For reset, you're looking about 2 to 3 minutes. A is filling up the blood. Pretty much that's it. On the button here, you reset, and it resets in seconds. Okay. The longest time taken is to actually
Change out the batteries.
If you change out the batteries, that will take a little longer. It takes about another 5 minutes.
Okay.
Okay, not very long. If he is getting low on batteries, this would tell you it's getting low, and you can pause it, do a swap out, put them back together, and hit continue, and he'll continue where he left off.
So one of the features I want to just go back and hit on, and we've kind of mentioned it in passing, we're calling that thing a remote control.
Yes.
You can use it to kind of set the scenario, set your starting parameters, but once you push start, it does not require you to constantly make manual inputs into the system, meaning you don't have to watch the student make interpretations as to what they did they do it right, how do I adjust the vital signs. This system, for all intents and purposes, is on autopilot, and it detects that, correct?
Yes, with the human physiology system we have in here, once you hit start, it runs itself.
And we were talking earlier, the other beneficial thing that I've seen this system be able to create is separation between the student and the instructor. Literally, the instructor can take a step back and not be over inserted into the scenario. Way back in the day, went to a lot of training where somebody got motivated, they went to the mall and they got a closed mannequin, that you would see up in the store, laid it down, moulaged it a little bit, and there would be an index card taped to the chest that would say GSW, right leg, and what their vital signs were, what their AVPU status was, and stuff like that. But even with that, inevitably it turned into the student turning to the instructor.
Correct.
And this dialogue between the student and the instructor wanting to know, is he breathing? What's his pulse? How far away is the ambulance? This separates that. He's got chest rise and fall. He's got all the pulses. He's got, reactive eyes. This makes the student treat the patient. And it also keeps the instructor from over inserting themselves. Stop.
Correct.
What are you doing?
That-
Wait, time out.
That's the hardest part of the instructor
Exactly.
is not answering questions because all the answers are here. The old time where student goes, feels for a pulse, asks, does he have a pulse? Here, you actually feel for a pulse and you get a pulse if you feel for the right areas. Okay, so that's the hardest part of the instructor is from him giving them answers. They got to step back and let it run.
It's kind of like Captain Ron's. Whatever's going to happen is going to happen out
gonna happen,
there.
exactly.
Let's go and do this and see what happens.
And you see, I have my hands all full of blood. We make our own blood. Okay, our blood is organic powder mix, and it washes off.
Right.
It washes off my hands with hot water and soap. It washes off clothes. Like throw them in the washer dryer, it comes right off. Okay, it washes off the carpet and the floors just as easily. Okay, so it doesn't stain your clothes. It does for a second until you get put in the washer,
Right.
and it comes off.
So from my experience doing training, there's two types of people that show up to training: people that want to be at training and people that don't want to be at training. And even the people that are the huge detractors. What are we doing today? Oh my gosh, I hate training. You throw them in a scenario where this is in play and they get to actually do the things and test their skill. 10 minutes later, you index and you start your little hot wash. The look on their face, they realize, holy cow, that was almost real. That was as close to making it as real as we can. That reaction is very rewarding because you got somebody that's maybe tuned out to training, suddenly motivated about, oh my God, we should be doing this every month. Where have you been for the
It makes people want to train more.
Exactly.
Exactly. it does.
The other thing that I've gotten, whether it's 6 months later or a year and a half later, and even now in retirement, I still get a phone call or two occasionally from officers that I taught in the academy or supervised at the agency. Hey, we went to whatever it is, a gunshot wound patient, a stabbing, a vehicle crash, whatever the mechanism of an injury. Patient was jacked up. They're on the highway now. They got out. They were confident in their skills because they've had the opportunity to work on systems like this. And hey, we applied the tourniquet, and guess what? The bleeding stopped.
Correct.
Well, outstanding. We did it. Okay. And that kind of feedback is very rewarding. The level of confidence that this helps the students have is just night and day difference from some of the other stuff, because some of the other training, they know it was not sufficient. They don't leave that training confident in the equipment. They don't leave confident in their own skill set. This lets them see the equipment really do some stuff, and it really lets them see, hey, I can actually do this.
Right, exactly.
So that's the
I can
benefit
practice
to it as me.
for real.
Yep.
Exactly. We follow the 3 R's of learning: reading, writing, arithmetic. We have realism, ruggedness, and responsiveness. So we have, okay, realism, it looks real, feels real. If I'm working with a piece of machine that looks real, feels real, I'm going to be more enjoyable. Okay. Ruggedness, I'd be able to take it outdoors and move it around. I'm not stuck inside a clinic somewhere inside a lab where it's not coming off a gurney. So I can take it out and about, outdoors and indoors. Responsiveness, whatever I do or don't do to it, it's going to respond. Okay, either he's going to die or he's going to get better. Okay, so that's what our 3 R's are: reading, ruggedness, realism, and responsiveness.
So going back to the control, earlier you said there were some pre-programmed scenarios in there, correct?
So we have built the system. We have 20 scenarios here that are already labeled. Okay.
Do they have the ability to write their own scenarios and add that to the list?
Right after the select button is a modify button.
Awesome.
So you click modify, you can modify any scenario you want, and it's going to save automatically.
Very cool.
Okay. If you want to go back to its original scenario, you hit reset default to original, and defaults to original. Also defaults to 0. By 0, it means it zeroes everything out and you start from scratch on the scenario. So you got 20 of those built into the system here.
Because I know occasionally, there'll be a one-off call where, a squad or a group responds to a call, and it's definitely something weird. And you talk about it at grand rounds, and that's cool. But it would be really cool to then take, okay, Bravo shift, Charlie shift, and
Yes.
give them the chance to respond to and
Which
see how
what responded
what
to,
alpha
exactly.
shift responded to,
Yeah.
so they get the benefit of it. And that way you have the ability to program that in there.
Correct. Like I said before, when you use this in conjunction with a bioscience monitor, you can run except codes on it. You can run scenarios into the emergency room and monitor him as well. You can watch his SpO2 go down or up. You can change his waveforms. Okay, all different types of waveforms you can change it into. So we have to react to them and give a medication or IV fluids or blood.
So we've been mainly focusing on a human mannequin.
Correct.
We also have canine simulators.
We have two
as well.
types of canines. We have a canine hero that has 8 features built for more for like the technicians start IVs and stuff like that. Then we have the trauma canine, which is called Diesel, has 28 features, whereas all the limbs are changeable. We have amputated legs there. We have fractured legs. We can give them a needed decompression if you need.
Same level of fidelity.
Same level of
meaning
fidelity.
They breathe, they bleed,
They
pulses,
move, they breathe, they bark,
respirations.
they whine, they growl, and have breathing issues as well. So those you have for training as well. But pretty much, and they look and feel realistic.
Because there are
Made by the same company.
military working dogs out there,
Yes.
police dogs. There's a bunch, I think 5 states now that are allowing civilian EMS to treat and transport service dogs. So a lot of agencies are having to get caught up on that training and those protocols so that if they're called upon to respond, they actually have some semblance of procedure and guidelines as to what to do. I was just down in Florida last week and there were medics from all over the state there to learn how to do canine medicine. That's a good thing. And I think more states are going to follow in that direction. So I know there's a need for those systems out there as well.
You know, I've been with the company for over 11 years, and I've been with them in almost every situation that we've been out there. We've been out there in the rain, we've been out there in the rumbles, with the dirt and the bricks and the motors on top of them. And we've been also like just in the heat. We took out 229 palms. It was 130 degrees. My phone turned off. It was too hot, but he kept on moving. He kept on rolling. So he's built for all types of environments. In the snow as well. We use him up in the snow up in Alaska. So he's built for outdoors, but also use them indoors as well.
Very cool. Well, folks, I think we have run through what we wanted to cover and present about the systems. Garrett, Nathaniel, are there any questions that got entered into the chat box that we didn't manage to cover that we can address?
Yeah, David Hubler asks, does the mannequin react to temperature? Similar to your discussion related to vital signs correlating with loss of blood, will there be vital signs or any indicators of patients becoming hypothermic?
It doesn't change colors. It doesn't get cold or sweat with the heat or anything, but the vital signs will change if you want to. You can also override the program and manually change the vital signs to where it can do that if you need to. So you can actually override and do on the fly and make changes to the scenario if you need to. Anything else, Garrett?
Jeffrey Paul asks, how do you extend the time before the scenario ends and the mannequin dies? What do you think that for?
The scenario does not end until you tell it to. So you hit stop. Okay, so it goes on. The only thing that will kill scenario is the batteries go dead. But with that, you can pause it and interchange the batteries and continue as long as you need to.
Back up. Yeah, this scenario can go on for hours.
Yeah.
You know, I mentioned earlier, 10 minutes, that initial response, throw some tourniquets on, pack some wounds, throw a chest seal on, drop an NPA. All right, now we're waiting on fire and EMS to get here. All right, NDEX. Buddy, we can let this thing go.
That's why you say we can go from
for
point of
hours.
injury all the way to prolonged field care with it. In the same scenario. And make manual changes if needed.
And Jeffrey also asks, can you demo how the arm or another body part would come off?
Let me see if we can do that here. It takes a little bit. I don't have the extra leg with me here, but underneath here, there's a piece that comes off. It's still get the right angle for it. I'll just do it. Takes a little to get to it. See, so this comes off just like that. So the leg itself, so it has a little round here. The leg itself will come and insert it here. And you have 2 full legs. The sleeve itself will cover all this injuries right here.
This would just
That will
unscrew.
come off. And the sleeve will cover this injury and that injury, and you have 2 full legs. Or a fractured leg. It would just go right on here. That's how it's done. Anything else?
Chad Callison has a question here. Where do you attach the leads or pads to if you're using your own monitor?
You attach them on here, on him. So the leads will be dummy leads because all the vital signs and waveform will be coming from the remote control to the vital signs monitor or to the vitals bridge monitor as well that goes to your monitor. So the leads on him will be dummy leads, but all the information will come from the remote control to the actual monitor itself.
But it would show up on either that monitor or the student's own system using the vitals bridge as whatever it needs to be
Correct.
interpreted as.
Correct.
VTAC or whatever. It'll show up as that way on the monitor.
That is correct. Again, if you look here on the monitor itself, I can turn all the leads on, and it'll show all the vital signs on here. Okay, you got your heart rate, SpO2. You got your wave to waveform, your SpO2 waveform, the CO2 waveform, and ECG. It can be interchangeable. Any other questions? That's it.
Well, folks, normally we would be having this conversation about 30 times a day from a trade show booth. And I know not everybody gets the opportunity to go to the big trade show. So this is a way that we've come up with in the last few years of one maybe positive thing that came out of COVID, where we have figured out how to do, I think, a decent way of some demo on the computer and still being able to highlight. You don't get the same sensation of getting to touch it, play with it yourself, but hopefully we've given you a decent representation of what the system is capable of, how we would use it, why we would use it, and why it's beneficial to training and how we'll augment your training and help improve it. And that's all what we do is try to improve the training so that performance improves and hopefully we have a positive outcome on the patient.
Again, if you have any questions you can't think about now, but come up with later, you can just send us an email to the, we'll be showing our actual email address to the company, our phone number.
Yeah, when we conclude this, there'll be a screen that pops up that has the phone number and the email that you can call or email us with any concerns, questions, inquiries, anything that you need to talk to us about.